All right. So, well, I'll go ahead and get started here. So I'm Jeffrey Donnelson. I'm a neuroradiology fellow at the Cleveland Clinic. That's a center where we tend to do a lot of seizure and imaging, among other things. We're one of the centers in the United States where there's one of the few places where people will go to get second opinions for some of the more complicated things that can happen with patients, some of the more difficult presentations, and the more complicated questions of management. So we do see a lot of things, a lot of complex and interesting cases. And this should give you a nice selection for the different, some of the different indications for imaging and some of the ways that we can evaluate these conditions. So we will, the main role for imaging is to evaluate for, especially for reversible causes or for treatment management, treatment planning, and that can be especially helpful for patients who have what's called pharmacoresistant. So I went ahead and jumped to my fourth bullet point here, but so a lot of the imaging that we'll end up doing is to target areas of cortex in which are causing seizures. But we'll also see infectious causes such as HSV, that's herpes encephalitis. We also see limbic or anti-GAD encephalitis. Patients can have post-traumatic seizures after some type of injury. Children's imaging that can be due to non-accidental trauma, also can be from congenital abnormalities or post-infectious causes. HSV encephalitis, the first one here. So the telltale predilection of this disorder is going to be for the anterior temporal lobes. And what you see here is restricted diffusion, which we have our DWI, where we have the T2 bright signal in the left anterior temporal lobe, matched by the hyperintensity on ADC. Here on the FLAIR imaging in the bottom left, you see expansion of that cortex and a loss of that normal pattern of gyration and sulcation. So that you can look to the contralateral side for your control, and also see how markedly different those two halves of the cortex are. And then the coronal images here give you a better profile view, especially of those hippocampi and the amygdala, just the marked degree of difference that you see there. So blooming susceptibility artifact can be associated with HSV, and that's if it's hemorrhagic. Chronically can create mesial temporal sclerosis and thus provide a locus for epilepsy. And then it may have some variable level of enhancement, but that tends to happen later in the disease course. And of note, for those of you who have worked in ICUs, the value of having this entity in your differential is it's very treatable. That acyclovir can be started and arrest this progression, which you will see. So we have the same patient 6 months later. So just to compare the coronal images, you see how distended and swollen that is, and now being replaced by evacuation, loss of that cortex, thinning of the margins, and this, if you look, this is your healthy hippocampus, that seahorse shape, and you see that that's just almost completely lost there, just markedly thinned, and loss of cortex on these anterior parts. And we go to 5 years later, and you can see the sequela here. There's only the varus outline of cortex along this left anterior temporal lobe. And it's as if there were a large territorial stroke. So this is really devastating consequences. And then you can see that ex vacuo ventricular dilation. So this is HSV, so one of the bigger acute infectious causes of seizures. And another one more common in tropical areas, warmer latitudes in Cleveland. You'll see multiple ring enhancing lesions tending to favor the gray and white junction. So you see how these are all tend to be clustered right around that border between the gray matter and the white matter. And so these almost have kind of a Cheerio type appearance. And I wasn't able to find a case where you could see a scolex, which would be the larger portion of the organism. But fortunately, these patients are treated before those organisms can develop into that later stage. And of course, you can also see this pachymeningeal thickening along there. And so a lot of the evaluations that we end up doing for seizure disorders tend to have more subtle findings. I wanted to include a few cases here because they're not, and calling these findings are not quite slam dunks. You have, so if you can see here, the left hippocampus is being the normal contour, and then on the right you see that that's markedly thinned here. Well, not even marked, but and then you go over to the proton density coronal, and you can see that contour difference, but that may be all that you get. And that's just this wisp of flare hyperintensity, which doesn't really stand out well here. So this may be all your telltale signs, but these type of images aren't going to be all that you'll have for your surgical planning. So, and I'll get to some examples of PET MRs further on in the presentation. And so when you're looking for mesial temporal sclerosis, this is one important mimic, the choroid fissure cyst. So it can create the appearance that there's some kind of cystic lesion in the hippocampus, in the hippocampal formation, but actually it's in that fissure, and so it's not a true lesion. Other mimics that will have kind of a similar appearance there. So if you have an unfused hippocampal fissure, which is a normal variant where you'll have more of a cystic area that will be further posteriorly or dorsally, and then dilated Virchow-Robin spaces, which will have more of a clustered cyst type appearance. Rasmussen's encephalitis. This is a chronic inflammatory encephalitis with unilateral predilection and volume loss, and then that ex vacuo ventricular dilation. This is going to be more common in children less than 10 years of age, although this patient is 41, and it's often associated with intractable seizures. And then another way that you can confirm that there is a volume loss on one side is by looking to the contralateral side and looking for hypertrophy. So, which we can see here. So the left, you see that they have the ex vacuo dilation of the left frontal horn, and then that left caudate is shrunken, retracted, and then the right caudate is enlarged, and that's a sort of a compensatory hypertrophy. And so that can be helpful in when you're looking at trying to identify which is the diseased side. You can have seizures which occur secondary to post-traumatic or post-surgical changes. And here's our example of a PET-MR used in evaluation. So this is a patient with a left temporal lobectomy for epilepsy. And then you'll notice, of course, on the right, there's a remote right subdural hematoma that was evacuated. But this, you see this area of encephalomalacia in the left anterior frontal lobe, or left anterior temporal lobe, excuse me. And then when you go to the PET-MR, it's not just the area of encephalomalacia that you have here, but it's a larger territory of photopenia. And in seizure disorders, the photopenic region on the interictal scans tend to be the locus that's more, the hypometabolism is the area that's much more suspect to be cortex that can be epileptogenic. And so that's the interintegral imaging, which is much less logistically demanding compared to ictal imaging, in which you have a hypermetabolic lesion. Now, the issue with obtaining that ictal imaging is that you're required to be scanning the patient while they're seizing, and that can be difficult to plan for, and also to keep the patient in position for the imaging while they're having a seizure. So we tend to get interictal imaging, and that's much simpler to acquire, but it is nice when we have both the ictal and the interictal, and then we can have comparisons. So this is a neonatal seizure patient. So you'll see that restricted diffusion, with that DWI hyperintensity matched by the ADC hypointensity. And this is and these are going to be areas that are prone to infarction, and then you can see the susceptibility artifact within the sulci here. And these are areas of subarachnoid hemorrhage. And just of note that, especially if you have susceptibility artifact in the posterior fossa, that can be a cause for sensory neural hearing loss. And so these findings produce a constellation of sequelae, including infarcts and hypoxic ischemic encephalopathy. Now these are, there's the category of encephaloceles. These are very easy to miss while you're going through the patient's study. More easily seen on the coronal imaging, especially if you have high resolution scans. So you'll have a, so these are temporal pits in which you have a portion of the cortex which is herniated into an enlarged arachnoid granulation, and this can be a etiology for seizures. And it's it wouldn't, this finding in itself would be something that we would comment on, but especially in a study evaluating for epilepsy, we can, it's one that would be important to include. Now, one fake out that you can see here, if you were to have a vessel that was coursing along the inferior surface of the temporal lobe here, and there was a flow void, then it would create the appearance of entrapment, but you would need to correlate these in this appearance with the other orthogonal imaging to verify that it was true entrapment. One entity that we see not uncommonly is the tuberous sclerosis. And you have subependymal nodules, which have varying levels of enhancement. And you see that the susceptibility artifact on GRE or SWI, and indicative of calcification of these nodules. and then more subtly, you can see these bright spots on the T2 imaging in the cortex, which correspond to cortical tubers. And the hamartomatous tissue that are seen within the tubers can be epileptogenic. Yeah, so this is a young patient. This is a 3-year-old. And you can, once they get to be teenagers, you might see that sega around the foramen of Monro, the soda-ependymal giant cell astrocytoma, which itself is pathognomonic for tuberous sclerosis and sort of has that very characteristic location. This is Sturge-Weber, or encephalotrigeminal angiomatosis, and what you'll see is prominent in leptomeningeal enhancement, which is produced due to vascular dysregulation, which promotes venous ischemia and infarction. And you have this generalized atrophy of one side of the cortex, and then that right to left midline shift. And then when you're looking on MR, you'll see this susceptibility artifact corresponding to calcification of the gyri, and that's what's going to represent that classic tram track calcification that's described on CT. And tubulinopathies, this is a more rare entity, but you can see enlarged dysplastic basal ganglia. So you see the corpus striatum here. There's an obliteration of the internal capsule, and just a swelling of that putamen especially. And then there's these T2 hypointensity bands in the claustra. And what you see, you also see a simplification of the gyral pattern, and that can be it's not the same mechanism as lesioncephaly, but you can have findings of lesioncephaly within a tubulinopathy. And polymicrogyria, and these can be very subtle lesions to detect, but your symmetry always being your friend. Polymicrogyria results from ischemia of a neuronal layer 5 during development. You have abnormal thickening of the gyri and loss of the sulci. Here you see the left occipital and then the right parietal fissures, and are correlated with our SPECT targeting. That these areas with that abnormally thickened cortex, which is somewhat dysplastic, can be sites for that can cause seizures, and that it can also be targets for resection. You may see schizencephaly with these patients, and it can also be associated with muscular dystrophy. And you see that hyperintensity on the SPECT imaging there. And so the low-grade neoplasms are often a source for seizures. High grade can also, of course, cause seizures, but the low grade are the ones that may cause a more indolent course. And this left posterior temporal lesion has a appearance that's consistent with a ganglioglioma versus a pleomorphic xanthorastrocytoma or PIXA. And this ultimately turned out to be the low-grade glial or glioneuronal neoplasm, but this is a very characteristic location for a ganglioglioma or a PIXA. And then the DNET, or dysembryoplastic neuroepithelial tumor, that's a non-enhancing cystic bubbly mass in the temporal lobe. So you'll see that in that same location for which HSV has a predilection. and we see that cortical loss and that enlargement. These are usually treated by resection. And this is an entity which is supposedly rare, but we've been seeing it more often. This is the rosette-forming glioneuronal tumor, and cystic, solid, with variable levels of enhancement. It's usually associated with the fourth ventricle and the cerebral aqueduct. Differential diagnosis would include the PIXA, the pilocytic astrocytoma, and the ganglioglioma. And this is the hypothalamic hamartoma. You see here, it's contacting the dorsal infundibulum, and it's iso-intense to the gray matter, which cues you into its hamartomatous nature. It's associated with gelastic seizures and precocious puberty. And these are very amenable to resection, and particularly that endonasal transsphenoidal resection. Cavernous malformation, and these have susceptibility artifact, tend to be peripheral. They have those popcorn T2 hypointensities. It may be congenital. They can be acquired, that is, in post-radiation treatment, and they can cause hemorrhaging if they become very large, but often they are incidental. And here we have hyperammonemic encephalopathy. And so in more mild cases, you'll see restricted diffusion and T2 and flare hyperintensity in the insula, the thalamus, and the posterior limb of the internal capsule, and the cingulate. And when you have it in more severe cases, then you may see diffuse cortical edema and hyperintensity with sparing of the perirhodontine and occipital regions. And then the last case I have here, this is called Perry-Romberg syndrome. This is a facial hemiatrophy, is the most pathognomonic symptom. You have T2 and flare hyperintense white matter, usually involving the parenchyma, which is ipsilateral to the facial abnormalities. And so the parenchyma will atrophy over time. You may have seizures, migraines, and trigeminal neuralgia. And you see here the difference between the muscle bulk here in the temporalis on the left versus the right, and in the muscles of mastication, and a much larger degree of fat here on the right side. And then you go up to the cortex, and you can see that those sulci are quite wide and the gyrae are quite thin. So there's cortical thinning actually bilaterally, but more so on the side which is ipsilateral to the facial hemiatrophy and the T2 and flare hyperintensities. And so these are the cases I brought tonight. So we have just I appreciate your time and concentration, and that seizures and epilepsy can arise secondary to a variety of etiologies. Accurate patient history and well-delineated imaging findings can help to direct treatment, including surgical management. So I will answer any questions you guys have.
Oh, thank you. So these are all the cases that you have met in your practice, yes?
Well, these are just a selection of cases from different etiologies. Like, so kind of some representative findings from different, from the different causes. Okay. Anything else?
Maybe someone else has a question. Scott, Ahmed, Bayram, Anna.
Oh, something in the chat. Oh, thank you, Anna. All right. right. Well, I think yeah, I can. I will. Alex, are you the organizer?
Yes.
Okay, I'll share my slides so that they can be available. Oh,
that would be wonderful. Yes. So today, our speaker was host for today is Jeffrey Donaldson, neuroradiology fellow and diagnostic radiology. That's past diagnostic radiology residency at Cleveland Clinic Foundation. And his topic for today was imaging for seizure disorders. I think that the recording of this webinar would be helpful on Reddit. Thank you very much for hosting the lecture today.
Yeah, thank you.